This week on the BackTable podcast.
It's one of the crazy exciting things where I recently had a dog. We did an RFA. Within days, the dog is back to walking like he never had the tumor there at all. And we can get him into chemo. We can get him into kind of the care that they need without this affecting their quality of life. And so I do think that's going to be huge as we start to learn how to do ablations more and really refine it for our patients.
Welcome to the BackTable podcast, your source for all things endovascular or otherwise minimally invasive. You can find all previous episodes of the podcast on iTunes, Spotify, or BackTable.com. Subscribe to the podcast, leave us a review, or reach out to us on Twitter or email to let us know how we can make this a more valuable resource for the endovascular community.
Now a quick word from our sponsor.
Our next partner has a product I use literally every day. I started taking AG1 because, quite frankly, they advertise with us and send it to me for free. And because my friends Aaron and Sabine use it. But truth be told, I've been taking it for, probably 75 days now, and I'm not stopping. You guys still taking it?
Yeah, for sure. Yeah.
What's your experience been like?
I honestly, I thought that maybe it would taste bad or something when I first got it, and I really like the taste. So it's kind of a pleasant drink for me in the morning, and I feel like I'm drinking something really healthy. It's really green.
Yeah, it's literally that and coffee. I don't like Mike. We always joke that maybe there's something addictive in the athletic greens itself, but my body craves it every day, and it's easy to take. It's a great presentation, and I feel confident that I know I don't need to eat a salad that day. Like I'm getting everything my body needs.
No, totally, I agree. It for me, it is at least partially mental in the sense that You see what's in this, you read the back of it. I'm like, this hopefully will counteract the damage I'm doing to myself on a weekend of call. And I'd say this jokingly, I'm a success story. You don't actually have to be an athlete to get effects from athletic greens. So for me, it's more of an academic greens. It supports mental health and clarity. And you can tell from how, my clarity right now that it's working.
That's great. I love that. It actually helps recovery from a bad weekend call. Not necessarily a workout, but a bad weekend of call.
No, you don't even have to work out.
Yeah,
I'm living proof.
All that food, all that junk food you eat on call, and you can at least tell yourself, okay, I had a 3 glasses of athletic greens over the weekend. Like I'm okay.
No, it's good. It's low calorie, low sugar, and to me, it tastes like a little bit like a pina colada without the alcohol. And so, I get back on that horse on Monday after a weekend of call, and this makes me feel like I'm getting close to my baseline. I'm getting a little bit better. But to make it easy, Athletic Greens is going to give you a free 1-year supply of immune-supporting vitamin D and 5 free travel packs with your first purchase. All you have to do is visit athleticgreens.com/BackTableVI. Again, that's athleticgreens.com/BackTableVI to take ownership of your health and pick up the ultimate daily nutritional insurance.
And now back to the show.
I'd like to thank our listeners for tuning in to another episode of the BackTable podcast. This is Michael Barraza returning as your host, recording in Baton Rouge, Louisiana. It's an honor to welcome our guest today, Dr. Chris Thompson in San Diego, California. Chris, thanks for joining us today.
Yeah, of course. Happy to be here.
Chris is a veterinary surgeon focusing on surgical oncology, interventional radiology, and minimally invasive surgery, which is a lot. You're clearly very specialized. I'm also joined by my friend and co-host, Aaron Fritts, recording from Dallas, Texas.
Thanks, Michael, for having me.
And we also congratulate Chris. Chris has a new baby.
Yeah, absolutely.
Chris, how's dad life?
It's good. It's different. It's busy. She's kind of taking it easy on us so far. She's a good sleeper, so definitely appreciate that. But it's been good so far.
Nice, man. Congratulations. Yeah, we already did the usual and asked everybody about their weather. It's hell where Aaron and I are, and it is perfect where Chris is in San Diego, like it is every day.
Yep. We went on a walk and already stopped by the pool this morning.
Nice. But the pool's chilly though, right? You don't get the bathwater pool like we get down here in Dallas. Is it nice?
It's kind of embarrassing to say it's a heated pool in San Diego. So despite it always being beautiful and 70 degrees, I still heat the pool. So cannot complain about the water temperature.
Oh, fine.
Enough
All right,
with
well, enough about you. Let's talk about me. But no, let's talk a bit about this. And so, just for our listeners, I'm super fascinated by what Chris does, and where this began was I saw a tweet that Chris had put out about doing a PAE on a dog, and like a lot of other people, I was just blown away. And I had to ask him to come on the podcast. I'm really grateful that he joined us. And I want to hear a bit more about that PAE too. But, just reading your bio, I mean, you are, you're wearing a lot of hats. You're doing a lot of things. I mean, you're a surgeon, you're an interventional radiologist. What did training look like for you? I mean, how did you learn all of this?
Yeah, it's kind of cool. It's veterinary medicine is great in that you kind of get to specialize in what you want to specialize, and you can really drive your training however you want it to go. And so I was very fortunate. I've been very fortunate throughout all of my training to kind of meet the people that I've met and learn from a lot of exciting different aspects of veterinary medicine. So it's quite similar to what's done for what we call human interventional radiologists. So I went to vet school. After vet school, we had an internship and then a 3-year surgical residency. And residency, it's not subspecialized. So we learn orthopedics, we learn general soft tissue surgery, cardiothoracic, urogenital, all of that in one. But within that 3 years, you kind of get the option based off your program if you want to really dive deeper into certain areas. And so during my residency is when I got a lot of my IR training. So I was at the University of Minnesota, so very fortunate. The cardiologist at University of Minnesota, Chris Thompson, has done a ton for interventional radiology, as you can probably suspect, but a lot of heart diseases in dogs. We don't do a lot of open heart surgery. It's not easy to get a dog on and off a pump. And so a lot of those procedures have gone to IR for cardiovascular interventions. And so Stouthammer at Minnesota has done a lot for cardiovascular IR. So I learned a ton of the basics from him. And then very fortunate to spend time at the U of M med school as well. So Shamar Young, who's an interventional radiologist, pretty big into PAEs actually, and a lot of other things, especially IO. He taught me most of what I know, especially for embolizations and interventional oncology. I got to spend a lot of time with him. And it was one of the most profound impacts I've had in my training, just the ability to spend time with him, to go through cases with him at the med school. And then he actually came to the vet school and would assist with some things that we were doing. So one of the first few cases that he came over for was a chemoembolization on a dog with a unresectable liver tumor. So learned a massive amount just kind of working through those cases with him and then adapting it to dogs. And then after residency, I went on to do a surgical oncology fellowship at Colorado State. So that's kind of what got me really solidified into the field of oncology care and really adapting interventional radiology, interventional oncology to my patients now.
Right on. So where do you primarily practice now? I mean, you're in San Diego. What kind of facility is it?
Yeah, so I'm at it's called the Veterinary Specialty Hospital of North County in San Diego. So we have 2 practices in San Diego. We have our southern location in Sereno Valley. We have the northern location, the North County Hospital, and that's the one that I'm at. It's a multi-specialty practice. Is kind of how most veterinary specialty hospitals are now. So we have basically all the specialists in one. So we have internal medicine, emergency critical care, surgery. We have cardiology, dermatology, neurology, all of those specialties in one hospital. And it's kind of nice because I have really built my practice within that hospital specifically for, again, those kind of big things of surgical oncology, minimally invasive surgery, and IR.
That's rad. That's awesome. So one of the other questions I had is, there probably aren't a ton of people that do what you do. And I'm curious, what that community is like. I mean, do you have a group of other surgical oncologists and interventional radiologists that you communicate with and share ideas with? Or, do you really kind of learn more from the surgical and IR communities at large?
Yeah, it's definitely a mix of both. There's a small but incredibly passionate group of veterinary interventional radiologists. So similar to the human side, we have a society, so the Veterinary Interventional Radiology Interventional Endoscopy Society. And through that society, there's a couple of very big, impactful veterinarians that have really bulldozed the way for IR and vet med. And so there's a lot of people that will do some dabbling into IR. There's a few people that are solely focused on IR and really do more of these advanced procedures like me. And a lot of it, again, even for my training, has come from traveling across the U.S. just to spend some time with those various people. So spent some time with Chick Weiss in New York City to learn from him, and Bill Culp up in Sacramento at UC Davis to learn from him. So there's a lot of people that are really advanced in the field that are now training others like myself to do some of these bigger procedures.
And that's great.
Yeah, are those people mostly at academic centers? Those like more 100% IR or more focused on IR?
Yes and no. I think that historically, if you wanted to do heavy IR, you were generally not stuck, but often would gravitate towards academia just because you have the ability to get the specialized cases, get those tertiary referrals to do so.
Right.
Myself and a couple others are now really moving towards doing this in private practice. And there's definitely a model to be able to do it and to make it affordable and to get those cases. But it's kind of a slowly growing field.
And
Totally.
do you have like an estimate of how many veterinary IRs there are in the country or even in the world?
Yeah, it's one of those things where if you go to a specialty practice, there's probably somebody in that practice that will do some degree of IR, whether it's just something as simple as like to us, a simple procedure is a urethral stent, just popping one in for an obstructive tumor. And there's a lot of people that will do that and be comfortable doing that. But something like a PAE, that's much more challenging. You got to have the training, got to have the kind of equipment and support staff to do that. So that's probably done at, let's say, fewer than 5 places across the U.S. But again, it's something that's definitely growing every year.
Yeah, I mean, I would say that even a minority of human IRs are doing PAE. It's just super badass that you're doing that. So, I mean, you're also involved with some research, right? You know, you'd shared something, a grant that you had gotten recently. Could you tell us about, your research, how you got, your grant, what you're investigating?
Yeah, absolutely. So that's, again, kind of one of those really just fortunate things that I've been able to stumble into with my career, and that always been really passionate about clinical research and has really helped me get to where I am just by being involved with some of the clinical research in vet med. And so the practice that I'm at now, it's our greater kind of parent company is Ethos Veterinary Health. And within Ethos, there's a entire division of the company that's dedicated to clinical research in veterinary medicine called Ethos Discovery. And it's great because they allow us and support us and encourage us to do clinical research in private practice. And so they really set up the ACUC, the kind of background that's needed to be able to do clinical research. And then like you said, just recently, I was very fortunate to get awarded a grant for splenic artery embolizations, specifically for thrombocytopenia. And it's kind of crazy because things like that, like the idea and my understanding truly came from learning from people on Twitter talking about cases. And it sounds crazy, and a lot of people give me hell for it. But like there's this community of such passionate IR doctors on Twitter that for me has been immensely beneficial because you'll throw out cases, I'll hear about it, I'll kind of learn from that case on there and then do a deep dive into the literature and see that, hey, this is something we could do in dogs. This is something that could be immensely beneficial. And so all of this, again, came from seeing a case of a splenic artery embo and the reactive thrombocytosis. And this is something where dogs actually very commonly get immune-mediated thrombocytopenia, and it's something that they can become refractory to standard treatment. So why not do something that's already been experimentally proven in dogs and is done in people on the actual clinical side in vet med?
So cool. It seems like it would be such a fun time in your specialty, which seems like it's relatively early. Erin and I were messaging with one of our partners, Allie, and she said she has this idea of you as like Charlie Dotter, who's like one of the inventors of IR, just coming up with these great ideas and doing them, and it just sounds like a blast. I would have so much fun sitting down with you and just like looking at your list of cases, for the last month and going through it. I wish we had that opportunity. But, again, I'd mentioned there, and you confirmed there aren't a lot of people who do what you do. And I would imagine they're clustered in large cities. So how do people find you, for an intervention that, you're one of only maybe a dozen people that can do? Yeah,
that's honestly one of the hard things, especially because it's not, a lot of these very new procedures are new and not well known. So even like a PAE, that's something that I learned from, again, one of my mentors, Bill Culp at UC Davis, who now he's done anywhere from 60 to 100. I have no idea how many he's racked up now. But he was kind of the one that pioneered that in veterinary medicine. And so he definitely has this following. He has this referral for PAEs at his practice because he's done it. People see how good they do, and then he will get more referrals because the referring veterinary community knows about it. So when I came to San Diego, it was one of those things where I showed up and I would get referrals for certain things. And then as soon as someone referred me for an IR case, I'm definitely just reaching out to those veterinarians to say, hey, this is what I did for the case. This is why. This is how great the patient's doing. These are the other things that I can do. And even for the PAEs, for example, like stepping into this practice, there are three medical oncologists and a couple of radiation oncologists that often will get the prostate tumors and be frustrated because there's not a lot of good options for them, especially when they get huge in dogs. And so just like talking to them and saying, hey, I can do this, and then make sure that first case goes really well. And after that first case went well, then they just kept referring more and more. So it's really a slow build, but it's something that it's all about kind of getting to the grind and talking to the referring community about it.
You have to excuse my laugh. I thought you were going to say that they got those patients after when like, oh my God, this sucks. The tumors are gone because you did such a great job.
Yeah, it's been great to partner with a lot of those people because again, they'll have cases that like they don't even know what to do, but like I have this complex case that I'm out of options. Is there anything that is done in the IR field? And often like we can come up with these ideas and procedures that is commonly done in people, but it's just so early in vet med still.
But that's the best part. It's one of my favorite things about this specialty. It is taking a very challenging patient or case and just thinking outside of the box and finding a solution. I think, what you're doing is kind of emblematic of the best of our specialty. And it's just really what makes it fun.
I was just going to say, I think that IR is kind of the perfect field for veterinary medicine in particular, because like our goal is so much different than a human oncologist for these cases. Because my number one goal is to make sure that pet, that dog, that cat is minimally affected by whatever they're diagnosed with, meaning that if they have a prostate tumor, I just want them to feel better. I want them to not be affected by that tumor. So we're not out there trying to do a massive resection followed with massive amounts of chemo or radiation. We just want them to feel better and give them that better quality of life. And IR for so many diseases allows that with minimally affecting their actual quality of life after treatment.
Yeah. And like, for example, with BPH, I was just curious to know, do you also have the similar options like TERP and Resume and aquablation, all that stuff? Is that available as well? And PAE is kind of like just the tertiary option, or how can you tell us a little bit about BPH? Is it parallel to humans in terms of options?
Yes and no. So dogs definitely get BPH, but 99% of the dogs that get BPH, they're intact and we neuter them and they get better. So we actually are almost never doing a PAE for BPH. It's almost always for a tumor. Just because the majority of dogs will get neutered when they're young. If they develop prostatomegaly, again, 90% of the time it's going to be a tumor, not benign hypertrophy. So most of the times that I'm doing a PAE, it's for a tumor and not for BPH. And if they do get BPH, we just neuter them and that's not a problem. But then from that option standpoint, it definitely is a conversation with the owner, because if I see a dog with a prostate tumor to come talk to me, we'll go through a significant number of options, but it's typically limited to definitely a PAE. We'll talk about a resection if they want to consider like a prostatectomy in those cases. Yeah. Or considering something like SBRT, or if they, again, really just want to go palliative, just consider an indwelling urethral stent. So definitely have a row of options, but it depends on the client's goals.
So does it sounds like most of the IR that's being practiced in veterinary medicine is focused on IO, like interventional oncology. Would that be a fair statement?
Yeah, I would say it's kind of a mix, and it really depends on the cases that you're seeing. So again, I think the majority of people that are doing IR truly is cardiovascular. So we have and that's where it's kind of interesting in vet med, because there's no subdivision or there's no training that's specific for IR. It's typically you go into your primary specialty, which is cardiology or surgery or internal medicine. And then from there, you kind of pick up IR skills and treatments that are for the diseases that you see. So there are a ton of cardiologists that do cardiovascular IR, like things like PDAs or patent ductus arteriosus. A lot of congenital malformations are treated with IR. They do tons of balloon valvuloplasties, things like that. And so that's the cases they see. So that's how they use IR to treat those cases. As a surgical oncologist, I'm seeing all of these cancer cases. So that's where all my references are coming from. And then similarly, if you're an internal medicine specialist, then you're seeing nasopharyngeal stenosis that you're going to balloon or stent, or you're seeing kind of a lot of urogenital diseases that you're going to be doing ballooning or stenting. So it really depends on the specialty that you're coming from.
Interesting.
So in the surgical and oncology world, what are the more common procedures that you're offering?
From an IO perspective?
Or whatever. I mean, what does your practice look like on the IR side? What are the more common things that you do?
Yeah, so a lot of ours, definitely mine is very heavy into oncology cases. So a lot of embolizations, a lot of chemo embolizations. We do a lot of stenting for obstruction. So if it's like a caval obstruction, we'll do a caval stent. If it's a ureteral obstruction, we'll do percutaneous ureteral stents, things like that. So it's kind of a mix of either closing down vessels or shutting down tumors or opening up tubes, which again is very similar to most IRs, but kind of more depending on, again, client's goals and how the patient is doing. And then we also have a pretty significant number of kind of developmental congenital diseases. So for instance, just on Friday, my last IR case, I did a intrahepatic portosystemic shunt coil embolization. So it's kind of like the opposite of a TIPS, where I'm just shutting down a shunt.
Yeah.
A lot of dogs will develop with shunts within their liver, and traditionally we would have to dissect into the liver, kind of close that down, and it was a very morbid procedure. But again, they took tips from human IR and they developed a coil embolization. So I just go down the jugular vein and essentially coil off the shunt, and then the dog gets a normal blood flow eventually. So kind of a pretty wide spectrum of things that we're doing.
Is portal hypertension an issue in cats and dogs at all? I mean, they're not drinkers and they're not,
Yeah.
You don't know that, Aaron.
There probably are some.
I mean, Bratz's dog was a drinker, of course.
Yeah, I don't have a dog, damn you.
We do see some portal hypertension, but they generally don't get tips. It's usually not something that, like, usually if they're in that severe of end stage liver disease, the portal hypertension is not what's going to get them. So it's often not something we consider treating.
You're treating a lot of dogs and cats, right? So it sounds like. Do you also treat horses, cat, larger animals?
Pretty rarely. So my practice is only cats and dogs. So that's like all of the patients I'm seeing. That's all the patients I'm getting referrals for. There are some really fun things at the San Diego Zoo, for instance. They'll have a crazy case and they'll talk to me or someone else in the field, and we'll do intervention for a zoo animal. So just a couple of weeks ago, I had a patient from the San Diego Zoo that had idiopathic renal hematuria. So we did renal sclerotherapy on a dick, which is a tiny antelope. So we kind of get some of those fun cases and
that is awesome.
Try to make things work, but it's pretty heavily in dogs and cats.
When I was a fellow at Penn, I got so angry because I found out that one of my attendings had gone to the veterinary school and did a uterine artery embolization on an elephant, and I was absolutely livid that he didn't think to invite any of us to participate. It was just legendary. I would love to do that. One of the questions that our friend Allie had, as a very good question, is how translational is one procedure, from one animal to another? First of all, between dogs and cats, but to the animal you just mentioned that I never heard of. Doing a PAE on that animal, tell me what it's like doing the same procedure on different animals.
Yeah, it's always an adventure. I think you guys, I assume it's the same for you, but IR is one of those things where you go into a procedure and you have to have plan A, B, C, D, all the way down to Z, because you don't know what issue is going to run into, what is going to work for this particular patient, what wires, what catheters are going to be needed. And so it's always variable, even just going from a PAE in one dog to another. The anatomy is never the same. The sizing is often a huge restriction. So to me, it's relatively easy if I do a PAE in a 20 kg dog and I can get by, and I don't expect that to be as frustrating. But if I have a 5 kg dog, that's, if I have I've done it on a 3-4 kg dog, and that is just an
No way.
exercise in frustration, because we have to get pretty small with those catheters and wires. And again, the anatomy can be so different, and especially in IO, the anatomy is always so altered by the tumor itself. So again, it's one of those things where you can do all the prep you want and you get in there and you find a surprise. And so it's getting good at being adaptable in those situations.
And I'm sure you're dealing with relatively advanced disease with a lot of these. I mean, it's not like the dog can say, it's like, oh man, my pelvis hurts.
Yeah.
Like, you're probably seeing big tumors. Big tumors in small dogs.
Yeah, and that's kind of where IR is such a good option, is because like if I see a dog with a small prostate tumor, I'm going to recommend a prostatectomy because I have such a better tumor control with that. But if I see a dog with this huge tumor that's already outside the capsule that's going up into the lumbar spine, then a prostatectomy is not going to benefit that dog. So that's where the PAE really comes in to be of a benefit to them. And so we very sadly or unfortunately do see a lot of late stage tumors, a lot of late stage cancers. And so IR really helps for those patients. And again, very similar to humans, we also see patients with comorbidities with these diseases. So like if I have a dog that's 6 with a liver tumor, 100% I'm going to recommend we go in for a liver lobectomy. But if I have a dog that is 13 that has diabetes and hypertension, then I'm not going to want to jump in and do an invasive procedure. And so chemoembolization is going to be kind of the top of my recommendations, just based off of what is best for the patient.
In terms of equipment, you were touching on some of the catheters and stuff. Is it a lot of the same stuff that we're using that you used with Shamar up in Minnesota? I mean, same companies, Boston Sci, Medtronics, the Cook Medicals. Are they supplying with the same equipment?
Yeah, it's essentially all the same stuff. We very admittedly, we try to get things as cheap as possible. So it was great when I was at Minnesota because Shamar could just come over with a catheter that costs $1,000 that we wouldn't be able to use. But if it fell off the table, then it's something that we could use for our cases. And so the equipment definitely is a hindrance in a lot of cases. And so we look into kind of the just recently expired equipment. We look into the stuff that is getting resold because a hospital shut down and they're wanting to get rid of their inventory. And so our purchasing team knows that if I have a case or something, I'll send them this list of kind of crazy catheters and things, and they'll just go about trying to find those as cheap as possible. But absolutely, there is definitely a lot of this is just the same equipment that's used, that Shamar taught me to use for his cases, I'm using in my cases. And then if we can get it for cheaper, we do what we can to do so. Yeah.
What about imaging equipment? Do you guys have your angio suite? Can you tell us about that?
Good question.
Yeah. So right now I'm just using like a OEC 9900. So it's kind of an older mobile C-arm. There are a couple places in our hospital, very fortunately, is in the process of building a bigger hospital. So I have been promised I'll get a ceiling mounted, kind of hopefully something like a Philips FD20. But that's kind of the dream suite that there are very few of those in the US. So most of it is just kind of a mobile C-arm that we use for a variety of procedures, whether it's orthopedics or these IR procedures.
Nice. So also, with the catheters and equipment and everything, I mean, again, like these are variably sized patients and long catheters and wires. That's probably a big challenge. I mean, I'm really envisioning, doing the PAE on the 3 to 4 kilogram dog, and I'm just kind of blown away. And it reminds me of doing, cases on babies when I was a CHOP, and you move the catheter back, feels just like a tiny bit, and all of a sudden you're back into the aorta. And I can only imagine how frustrating those cases must be.
Yeah, for sure. And yeah, again, the smaller they are, the harder they are. So especially like cats, again, it's incredibly hard to do an intervention in some of the cat patients. So it's not as common in cats, and we have to adapt and do some crazy things. Like just for reference, we do a fair number of ureteral stents in dogs, and that's kind of easy because you can get by from a 2 French to a 6 French ureteral, like a double J ureteral stent in a dog. But a cat, like if you try to get a 2 French in, it's not going to fit because their native ureter, a normal non-dilated cat ureter, is 0.3 millimeters. So like to try doing an intervention on that is pretty impossible.
But how do you deal with the different lengths? I mean, do you just have a shit ton of different lengths available on your shelves, or do you have to modify?
Yeah, no, everything, like I have to get one of every size if I'm going to do something, and kind of keep one of every size in stock. And I'm often feet away from my patients, meaning that when I was with Shamar, we were like, you're right up at the access site, but for these patients, if I'm doing a carotid intervention, I'm going to be like 3-4 feet away from this Chihuahua, just because that's the catheters that I have to work with.
Yeah.
Wow. So we're talking about equipment that, disposables, equipment. We know this stuff's expensive. You're super specialized training. How do you determine the cost of a procedure?
Yeah, it's definitely challenging, and
Sure.
vet med costs are definitely rising, and it's hard to try and do anything like on a cheap version for these patients. And so everything that I'm doing definitely is insanely expensive, and unfortunately does preclude a lot of clients from being able to get these treatments. I'm very fortunate in San Diego. We have a client base that fortunately can afford a lot of this. But again, just to get a CT angio, it's a couple $1,000s. To do the procedure, it's a couple $1,000s. A hospitalization, anesthesia, aftercare, it's a couple $1,000s. And so all of that definitely adds up. There are a lot of cases that it's very fortunate if the pet is insured, then we have the ability to kind of ignore costs a little bit more. But that's one of those things if I have a case with a prostate tumor, I'm talking to them about, this is a cost just for the staging. This is a cost for prostatectomy. This is a cost for a PAA. This is a cost for SBRT if you want to do it. This is the monthly cost of chemo. And we have to be very upfront about that, because each step of the way, like if we spend too much money on staging, then we don't have any left over for intervention. And so it definitely goes into our care discussions.
Are there pet insurances that cover any of this stuff, or is it mostly cash?
Yeah, no. If a pet is insured, most of the insurance companies are going to cover all of this. Once a pet is insured, there's nowhere near the amount of restrictions as there are in human insurance. So if I do something, even if it's never been described in a dog before, the insurance company often will still cover that, because there's no standard of care that insurance is going to or is not going to cover.
Well, that's pretty cool. God.
Yeah.
That is cool. You don't have to do peer reviews and all of the bullshit.
Yeah.
Well, Michael, anything else you want to talk?
Yeah, I do. I got a little bit more. So, this is obviously a changing field and a developing field, and you're obviously a part of that, of the development. I'm just kind of curious, what the horizon looks like for veterinary and IR, and if there's anything that's kind of come down the pipe that you're excited about.
Yeah, I think the things that are now most exciting to me and some other people, the cardio guys are doing some incredible things. Like there are again, one of my mentors at CSU, Colorado State, Brian Scanson, like doing valve replacements via IR is just insane to me, and he's doing some really incredible things. And then similarly, there's a lot of us that are now getting into ablations. And I think that, again, for veterinary patients, I think that's going to be huge for us once we can really refine it for our patients. So, for instance, another thing that I've started in San Diego down here is to do radiofrequency ablation for bone cancer in dogs. It's one of those things where, again, our number one goal for these patients is to give them the best quality of life for as long as we can. And right now, if a dog gets a bone tumor of their limb, the standard of care is amputation followed by chemo. And a lot of dogs do phenomenal with an amputation, but that's one of the things that the holy grail is, if we can avoid an amputation and still get the same tumoricidal outcome, that's kind of exactly what we want. If we can keep our four-legged dogs four-legged, that's going to be the ultimate goal. And so there's a few of us that are now starting to do ablation. So again, it's a crazy small field, but Vincent Wavre is a guy, he was originally at OSU. He's now over in Europe now, but he started doing some microwave ablation in dogs as a form of limb spare for osteosarcoma. Learned some things from him, and now I'm starting to do some RFA and cementoplasty for, again, kind of appendicular limb-based bone tumors. And it's one of the crazy exciting things where I recently had a dog. We did an RFA. Within days, the dog is back to walking like he never had the tumor there at all. And we can get him into chemo. We can get him into kind of the care that they need without this affecting their quality of life. And so I do think that's going to be huge as we start to learn how to do ablations more and really refine it for our patients.
Does vertebroplasty or kyphoplasty exist in animals? I imagine they don't get compression fractures like humans do, right?
Yeah, so because they're quadrupeds, not bipeds,
Right.
we don't have the same kind of compression on the spine. But
Yeah, Aaron, they don't walk the same, Aaron.
the
My
general
cat
outcome.
does. My cat will get up on two legs.
Yeah, but it's one of those things where, again, all of what we're doing is so driven by what you guys are doing. And no joke, I was listening to BackTable about kyphoplasties and cementoplasties, and you had, I don't remember who it was, but talking about kind of battling with RT if you do the like biopsy, ablation, cementoplasty before RT or after, and kind of working with those radiation oncologists to get this hammered out. And that's one of the things that really drove down to me that this is something that we need to start doing. And so after hearing that on BackTable, then I went did a deep dive in the literature. And again, you kind of can adapt that to vet med just based off of kind of learning these techniques and seeing what you guys are doing as well.
Man, I think I speak for everybody. Like, keep sharing these cases on Twitter, man, because I'm loving them, and I'm not the only one. I was blown away with that PA you shared, and I hope you keep doing that.
Yeah, for sure. It's something that, again, there's not a ton of us, but there's a good vocal few of us that love doing this, and so the more people that know about it definitely benefits everyone.
The other thing that would be cool, Chris, and I'm sure you have limited bandwidth, but we just had our SIR conference. But it'd be cool to have you come and show a bunch of IO cases at a big conference. You know what I mean? Has anybody done that you know of in the veterinary world?
Not that I know of. I would love to. Again, I think that we have so much to learn. And the other thing is that it's only through these connections that really allowed this to happen, meaning that it was because of Shamar Young, an interventional radiologist that kind of took time with a pestering young veterinary surgery resident that allowed me to tag along and learn out of these things. And now that we can adapt this to veterinary patients, it's the same thing. So if there are anyone that has a MD DVM connection, it really improves both fields because, again, we can learn from you guys. And then the other big thing is really using dogs or cats as a model for human disease. So again, just from posting that PAE on Twitter, I had someone reach out to ask if we wanted to kind of work together on a preclinical study for PAE embolization using dogs as a natural model of cancer. And again, those are the things that if we can get funding from some of the bigger granting agencies on the human side to do some of these really awesome procedures in dogs, it benefits everyone because we can then give that high standard of care, high quality of care to our patients, and we can get the data, we can kind of see what happens for some of these things that benefits, again, both the human medicine and veterinary medicine side of things.
Absolutely.
Was that Nainish Parikh that reached out to you?
Yeah.
Was it really?
I'll have to check.
That would be amazing.
I hope it was 9.
There were
it was 9.
3 or 4
That's
people
great.
that kind of contacted me.
You're ahead of you're absolutely right. And what you're doing, the PAE cases, you're ahead of the game. You're ahead of what we're doing in humans. And I completely agree. I think we could all learn from your experience.
Yeah, that's good. And again, so much of it, like we are translating what you guys are doing to our patients. And there's a lot of things that we may be doing that, again, we are limited by finances. We're limited by certain things. And so we've kind of adapted and can share some of those, I guess, cheaper ways of doing things, even if that's helpful.
Hey, that's important.
Yeah. And on the ablation side, sounds like Steve Yevich would be a good person for you to talk to. He's doing some crazy stuff down at MD Anderson and in all different bones. And, so he has so much experience, and really his practice is all about bone ablation, so he'd be a good contact. But you probably know Sean Tutton there at UCSD. Do you know him?
Yeah, the name is definitely familiar. I haven't met him yet, but it's one of those things that I came to San Diego during COVID, so there hasn't been a ton of meet and greets with some of the MDs at UCSD.
Oh yeah, there are tons of them. My former co-fellow Quinn Meisinger is there. Yeah. There are lots of great people there. Yeah. So. Well, look, man, thank you for doing this. We really appreciate you joining us, and this is awesome.
Yeah, it's been my honor. I think, again, the more connections we can make with vets and human IRs, it definitely helps everyone.
I'm with you. And thanks to our listeners for joining us. Aaron, do you have anything else for us?
No, but Chris, much respect for you. And it's funny, I was pre-vet and into college until I realized that you can't get into vet school with a 3.5 GPA. You got to be 4.0 and above, right? But I also worked in a kennel for a year for a good amount of time, and so many dog bites that I just was like, I don't know if I can do this. So kudos to you, man. I know it's a long, arduous training process, and you guys are super sharp. Every vet I met was super sharp. And so, yeah, I just love what you're doing. And let us know if we can do anything for you at BackTable.
Yeah, for sure. Again, I appreciate it.
Yeah, we need to find a way to do another one of these. We'll find the right topic. But
the more the word gets out, the better. And again, there are some really phenomenal veterinary IR specialists that I would love to connect just to hear some of those other perspectives. Because there are a lot of guys that have built this profession and have done it in partnership with so many human interventional radiologists.
Cool. Well, thanks, Chris. Appreciate it.
Yeah, of course.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck,
Sabine Dond,
Michael Barraza,
and Ali Behetti.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
article and transcript support by Taylor Robinson,
And Delaney Aguilar.
Social media and PR by Ann Dang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.